Okay, so this is all trial and error. This is not a nice, clean, scientific algorithm. I've tried. I can't come up with one. Start with the CMC brace, if that's the complaint, CMC pain. Observe loaded pinch with the CMC stabilized, and then if that does not alleviate the pain, try other combinations. It is pointless to create any situation where there's a brace that the person is not going to wear because it's not going to be of any value. So you start with the CMC. I start with the push braces because they're readily available, they're easy, quick fit, don't have to make anything, etc. And what I'm looking for is getting that first metacarpal out of the palm. MP subluxation, there are lots of ways to go about this, some of which are fairly uncomfortable, all of which need a little pad in them to lift them off the bony dorsum of the MP joint. MP hyperflexion, there are multiple ways to go about that, including this one, which is using the MetaGrip, but placing a piece of thermoplastic material under the MP joint to prevent full flexion. And MP hyperextension, it is the most predisposing because that's what really flexes the first metacarpal. As it flexes it, that leading edge is what gets most of the pressure, and that's where the grind and the pain comes from. When you flex the MP joint, they've done a study at 30 degrees, then the CMC joint becomes more extended. So that's our goal, is to get the CMC joint in more of an extension, because you cannot have this arch if that first metacarpal's flexed. You just can't do it. MP hyperextension alone can be handled in many different ways. And the IP hyperextension, again, there are many different approaches. IP hyperflexion, you can do the same. Lateral deviation is sometimes a problem, particularly in the older patient, and that also can be managed with something small. We all are working to improve the proprioception and neuromuscular control of the CMC joint. And what I want to impress upon you is if you have the correct, accurate bracing, you are enhancing that, not diminishing that. You are supporting the whole role of re-education and control. So it's about choosing the orthosis that change the mechanics, not just changes pain. You can get rid of the pain by immobilizing the thumb. That's fine. It'll quit hurting. That's fine. But I would love us to focus on what's the long term of diminishing the pain. I have to say, I never have pain with my left thumb unless I've done something really stupid. And so I try, if I'm going out and trimming shrubs or doing something that I know is highly repetitive, I wear my brace as a preventative. But other than that, I do not have CMC pain in my left thumb anymore. But you've got to make it minimally intrusive, because if you don't, it's not going to be worn. And not all patients need the same brace. The goal is to alter the load. That's really what we're trying to do. And it is a process of trial and error. And we want to change their neuromuscular control, which is a long term. Okay. Those of you who use this brace, when you fit it to the patient, do you squeeze the metal insert? I have to say that it would make the difference between it being totally useless and really helpful. Yeah. Because it is designed that when you fit it, the muscles, your thenar muscles are relaxed. You squeeze the metal insert so it is secure around the relaxed thenars. And when the person starts to pinch, the muscles contract. They can't go anywhere because there's something there. And that internal pressure stabilizes the first metacarpal, and there's no translation. So it is a dynamic stabilization. But if it's not fitted to those relaxed muscles, and it's then essentially too big, then that would not occur and it would be totally useless. And I could appreciate that they wouldn't feel like they had any support. I have to say, in the United States, we really work hard to stress the need for this fitting. And I've noticed that in all of Europe, that focus on the squeeze has not really been as focused as it has been with us. So actually, Elizabeth Hagert, I had given her one, and she said, well, I don't find it very helpful with patients. And I said, well, do you squeeze it? And she said, no. I said, well.
For that, or
It was not designed for that.
Exactly.
That was the first tip. Okay, so you might think of choosing something else, number one.
Yes.
Number two, you can heat. This is a thermoplastic. It is just a higher temperature than the thermoplastics you have in your clinic, and you can heat that and bend it out.
Okay.
But you must be you must be very careful because there's metal right here. Metal will always absorb heat more readily, and it's quite easy. There's a fine line between softening it and burning it. And once you can't return it, obviously. But you can also trim this, a curved scalpel is the best way. You can just trim like that, and you can get it. But it was not designed for the sublux joint, and it does not fit well. It's high temperature. You cannot heat a big section of it at all. You just have to, it won't behave at all like your thermoplastic. You can leave this in the car in the summer with the car closed and the sun beating really hot, and it will be exactly the same. And, a car gets very hot.